Good afternoon, morning, or evening, everybody. My name is Brett Benkowski from the Cancer Biology 2019 Fall course, and I'm here to talk to you a little bit about osteosarcoma, the bony tumor. We'll be discussing osteosarcoma's etiology, so where does it come from, potential interventions, and what the long-term outcomes of osteosarcoma are. Osteosarcoma is a type of tumor of the bone that produces osteoids. Osteoids are the unmineralated components of the inner bone matrix. Osteosarcoma also produces mesenchymal cells, which is the term for the pluripotent stem cells that go on to form the support structures of the body, such as the bone. So while we normally think of tumors as being kind of squishy masses, osteosarcoma actually tends to be a bony tumor. It's hardened and ossified and is a rigid structure. Osteosarcoma tissues can appear anywhere that bone is found in the body. The skeleton is roughly divided into two sections: the appendicular skeleton, which is the arms and legs, and the axial skeleton, which runs from the pelvis to the top of the skull, not including the arms. Most osteosarcomas start in the appendicular skeleton, with 50% or more cases beginning around the knee, either towards the distal end of the femur or the proximal ends of the tibia fibula. The joint is often involved in osteosarcoma development and is therefore often involved in osteosarcoma resection as well. Less commonly, and as you get older, osteosarcoma begins to form in the axial skeleton, so the central part of your body. 10% of cases forming in the axial skeleton start in the pelvis, and cases moving up become less common until you reach the maxillofacial region, the head, where you have about 4% of cases. Because it's in a more operable location and you have easier access to radiation and other forms of treatment, appendicular osteosarcoma is more treatable and more common, while the less common, more difficult to reach axial osteosarcoma is the rarer of the two areas. So when we ask ourselves what causes osteosarcoma, we're confronted with the rather grim reality that we don't know. Unlike in breast cancer, where we've been able to nail down the culprit to say HER2 or being triple negative, there's no concrete culprit for osteosarcoma because the length and breadth of the research just isn't there. We have been able to identify p53 mutations, as in many other cancers, but p53 is inactivated via a very unique mechanism in osteosarcoma. The TP53 gene, which encodes the p53 protein, is actually inactivated by translocating the first exon of that gene to the fifth exon of FAM45A. This causes both protein products to be inactivated. FGFR1 is also an oncogene that's been implicated in osteosarcoma's aggressive metastasis. Osteosarcoma metastasizes frequently, often to the lungs, but if you block FGFR1 reception, lung metastasis decreases. So it's been implicated that FGFR1 is responsible for the aggressive division and spread of osteosarcoma. And also, a recent research article by Baroy has found that CHM and CHML, which encode REP1 and REP2, are tumor suppressor genes, or could be tumor suppressor genes pending more research. A mutation in the protein truncates the REP1 protein, which downregulates its activity. This is similar activity to large diffuse B-cell lymphoma and breast cancer. It's also similar to the retinoblastoma cases that we investigated in class. So when we picked up the retinoblastoma, we looked at it from the Rab protein function. Decreases in Rab protein function cause retinoblastoma. If we would have gone deeper into those cases, we would have found that that was actually a result itself of decreased vesicular transport in between the cells. Rep proteins are the step before the Rab proteins, where they act on the Rab proteins and cause the decreased vesicular transport. So Rep1 is the protein that is inactivated in retinoblastoma, but Rep2 is inactivated in osteosarcoma, leading to a hypothesis of similar tumorigenesis between osteosarcoma and retinoblastoma. So when it comes to treatment of osteosarcoma through the chemotherapy route, doxorubicin, high-dose methotrexate, and cisplatin are the most common drugs that are used. Unfortunately, osteosarcoma cells can become resistant to all of them. One study looked at resistance to cisplatin and a phenomenon called a drug vacation. So when it comes to chemotherapy, if you halt treatment for a little bit, the cancer can adjust to the new environment of the cell. In the case of cisplatin resistance, the changes are reversible, but unlike normal differentiated osteosarcoma cells, the resulting cells are unique. So here on the right, we have a picture of, let me pull up my laser pointer again, boom, boom. Osteosarcoma here is our normal cell, so this cell was never treated. This cell was treated and has now become resistant to cisplatin, and this cell was given a drug vacation. So you'll notice that some similar regions exist, but also very different regions exist between the resistant and the drug holiday given cells. So this could provide us new ins to attacking the genome of these cancer cells, because we can manipulate them directly through our treatment patterns as well as the treatment themselves. This treatment is effective, has been shown to be effective in a few isolated cases. It's definitely not approved for widespread use yet, but it does involve halting a treatment, so it's not appropriate for highly metastatic cases. However, if you're able to catch osteosarcoma early, it may be appropriate for helping patients fight the tumor within a relatively quick time frame. This is an image of gene expression in osteosarcoma cells. So if we look on our right side here, first we'll see some familiar faces with TP53, BAX, BAD, BAC, BID, BAC, and BCL2. All the tumor suppressor genes have been, and apoptosis inducing genes have been downregulated, where we see our old friend BCL2, which inhibits apoptosis, upregulated. So in our osteosarcoma cases, we're starting to see characteristic inactivation of apoptosis related genes, and then we come over to the left side here and we see the drug resistance related genes, especially ABCB1, has been upregulated significantly in osteosarcoma cases. So this is just another little look into how the drug holiday concept could work with the gene expression profiles in order to make the cancer more treatable or provide a different angle to treating the cancer. So if we start with parental osteosarcoma cells that are sensitive to drugs in a way that a typical osteosarcoma cell is before treatment, and then we give it cisplatin treatment, high-dose methotrexate treatment, whatever treatment you want to give it, at the end of the round of treatment, you'll end up with a cluster of cells that's resistant, because osteosarcoma is generally resistant to chemotherapeutic measures. If you stop treatment, what was actually found by this study was that after a certain amount of time, and it depends on the tumor and it depends on the patient, eventually you would remutate to have drug sensitivity again, but with a completely different gene expression pattern, as I showed you 2 slides ago. So this is now receptive to drug treatment again. It would allow you to resume chemotherapy. So this provides a really interesting window into how we can play the long game against osteosarcoma, which really isn't heard of. Osteosarcoma outcomes aren't good, but if we can find a way to selectively attack the cells and get the tumor cells to be composed of what we can attack again, our long-term outcomes for managing osteosarcoma might start to look up. I also want to talk a little bit about the surgical intervention side of osteosarcoma, because I think it's really cool. So over here on the right, we have an image of first the osteosarcoma tumor, which is this dark mass here. The osteosarcoma was removed after treatment, and actually this long bone here is grafted fibula. So they actually were able to take the fibula from down here and graft it to the humerus in order to preserve the growth plates and allow normal growth in a patient. So getting more into the nitty-gritty of the surgical resection process, surgical intervention remains the most consistent way to attack an osteosarcoma tumor. Ever since treatment first started for it and continuing today, complete resection of the initial tumor seems to be the most effective way to prolong lifespan. Thanks to recent developments, we've been able to either spare or amputate limbs depending on where the tumor is located, which gives you a chance to save a limb in a patient that doesn't necessarily have to lose it. The treatment must also be coordinated with chemotherapy, radiation, and actually other pathology within the tumor. So to give an example of the other pathology, this is I'll pull up the laser pointer again. This is a pathologic fracture in the femur. you had to wait for it to heal, and you can actually see the tumors formed here. In the time it took for it to heal, the tumor was actually able to grow, but unfortunately in this condition it was inoperable, so they had to wait in order to treat it later. When it comes to chemotherapy and radiation both can make the immune system weaker, so you have to coordinate surgical intervention in order to ensure that the patient is not put in extreme danger due to chemotherapy and radiation complications. The surgical process itself is relatively straightforward, or as straightforward as surgery can be. Step one, you resect the tumor. You take the whole tumor out. If the tumor is adjacent to a joint, the whole joint can also be removed. An optional step in the tumor removal process is if the tumor is metastasized to the lungs. Thoracotomy, so cutting into the chest cavity, may be performed to get metastases out of the lungs. And then step two is limb conservation. So if the limb is to be preserved, either live grafts or prosthesis may be employed. So moving into limb conservation discussion, we really have two options thanks to modern medicine. We can do a bone graft or we can do prosthetics, and some surgeons have been using a combination of both. So assuming you can find a match similarly to an organ, you can graft bone from another patient into the osteosarcoma patient. Because it's a live transplant, the transplanted tissue must be matched, and there's a potential for infection and non-union. The body can reject the transplant. But a major advantage is that in younger patients who are still growing, growth plates can be transplanted into the patient. The opposing option is prosthetics, which is a shorter term treatment. It's definitely not as durable as the actual bone, but it's always available because it's manufacturable, and because of the way that it's implanted, it's more difficult to reject. However, when it comes to prosthetics, the growth must either be planned for by using a larger prosthetic early or accounted for with adjustment surgeries later on. Osteosarcoma is radioresistant, so this limits the use of radiation therapy to non-resectable tumors or widespread metastases. So radiotherapy can be used to increase long-term survival ratings, but it's not useful to the point where it can cause the tumors to go into remission, so it shouldn't be used as the only line of treatment unless nothing else is possible. In one study, 30% of cases reached local control in 5 years, meaning a tumor either stopped growing or became smaller. Your chances of good results from radiotherapy increase if your tumor is located in the extremities, if the patient is younger than 20 years old, which not luckily, but fortunately for radiotherapy, several of them are, and also surgery to resect the tumor as much as possible, all improve outcomes significantly. This is just what I meant when I mentioned outcomes without surgery are significantly lower. If you have radiotherapy with surgery, generally, time without remission is longer. But if you either don't have surgery or if the tumors are recurrences or metastases, your relative lifespan is significantly shorter. So when it comes to the overall outcomes of osteosarcoma, the outcomes are bleak. 80 to 90% of patients are assumed to have micrometastases, and 10 to 20% of patients have visible metastases at diagnosis. And as you saw in the last charts, as you have metastases and recurrences, 5-year survival decreases. 90% of metastases show up in the lungs, 8 out of 10 show up in bone, and a negligible few show up in lymph nodes, and some can even actually manage to jump outside of the skeleton and form bony tissue in soft organs. Your 5-year overall survival rate after metastases is between 23 and 29%, and because osteosarcoma is frequently recurrent and aggressively metastatic, 5-year survival worsens with each occurrence, dropping down to 0% at 5 recurrences. So just some parting thoughts in order to close out the session. Osteosarcoma is a bone tumor that creates more bone tissue. Surgery appears to be unavoidable in order to maximize long-term survival rates. Without surgical intervention, 5-year survival rates are very, very low. But a combination of surgery, chemotherapy, and radiotherapy have been shown to provide relatively longer lifespans over 5 years to patients. Drug vacation therapy is experimental but provides one promising way that we can use what we currently have in order to treat osteosarcoma, especially since chemotherapy outcomes have plateaued. So we've been able to achieve successful results in several cases with chemotherapy, but we haven't made many improvements in recent years because it doesn't matter how strong you make the drugs or what drugs we try, we can't seem to find a better way to treat what the tumor is doing than what we currently have. So we're looking at a lot of alternative methods for how to treat the cancer. And because we're looking outside the box, we're trying experimental therapies such as chemo and angioembolization, creating clots that starve the tumor of the nutrients it needs, thermal ablation, so overheating the tumor to cause the cells to die, radiofrequency ablation, so looking to target radiation to see if we can make radiation more effective, and cryotherapy, freezing tumors out. So with that, thank you very much for watching. I hope you have a great afternoon and enjoy your holiday break. Bye-bye.